Welcome back to Introduction to Food, Culture, Society and the Individual and the Social Determinants of Health, Session 1, Part 2. Continuing on with SES and its relationship to health, it's not that being of a low socioeconomic status has a direct effect on causing ill health. It's, of course, the ramifications of low socioeconomic status. A person may, for example, not have access to good dental care, and that might lead to tooth decay, which leads to poor eating habits, which leads to also inflammation and nutritional deficiencies, which leads to poorer health outcomes. Other factors could be things like the cultural and social influences that might occur in lower socioeconomic groups, where possibly poor food behaviours, such as eating a lot of takeaway junk food, that kind of thing, might become the social norm. And also cultural practices that are passed down from generation to generation when there is a low socioeconomic status amongst intergenerational groups. And so, so that's something that's important to consider, because if we can actually look at what the determinants are, what the actual causes are in relation to low SES, then there can be attempts made to actually address those determinants and actually try to improve the health outcomes of people despite being in a low socioeconomic class. So people who come from lower socioeconomic groups, they tend to suffer from higher rates of obesity, type 2 diabetes, cardiovascular disease, osteoporosis, dental caries, and some forms of cancer. And we know that a lot of these conditions, or all of them, can be directly linked to diet and nutrition. We also know that people in higher socioeconomic groups, they tend to be thinner. They tend to make better food choices, so less intake of refined sugars, empty calories, trans fats, and saturated fats. And along with that, would be influenced by things like better educational status, better nutritional literacy. And people in the lower socioeconomic areas also might be surrounded by fast food restaurants, and so the influences around them are pushing a lot of these unhealthy dietary behaviours and unhealthy dietary choices. They're being pushed by the environmental aspects of where they live as well. About 1/6 of the burden of all disease is caused by socioeconomic disadvantage. So the job that you work in as a measure of socioeconomic status is a better predictor of cardiovascular death than cholesterol levels, blood pressure, and smoking combined. Now this is a really fantastic, I suppose, reframing of the way that we consider risk factors for cardiovascular disease. And I think, there's so much emphasis placed on cholesterol levels, what's your cholesterol levels like and what's your LDL, and more controversy over the relevance of things like LDL cholesterol and how actually, how good is it at predicting heart disease. And, as this statement says, if people actually were asked about their work and asked about whether they enjoyed their work and what kind of work conditions they had, and then we put resources into actually addressing some of the problems associated with some workplaces, then actually it might be a better approach than just focusing on cholesterol alone. Biological factors are less of a risk in developing severe chronic diseases than dropping out of high school. So again, if someone drops out of high school earlier, then that doesn't directly mean that they're going to get heart disease. However, it may mean that they end up in a lower socioeconomic area where they live, and all the various ramifications of that, social and physical, will come into play and potentially influence the health outcomes of that person. Physiological stress is also something which tends to increase in lower socioeconomic groups. So people who have rent stress, they have bill shock, when they get a phone bill or an electricity bill after a really cold winter or a hot summer, and suddenly they've got $1,000 of a bill to pay. They can't pay it, and it can cause huge stress in the family, and then that can lead to health outcomes on its own. I mean, we know that there's a direct link between high stress levels and stroke risk, and so very easily you can see the link between socioeconomic status, stress, and stroke. Inflammatory responses that might occur also in relation to stress can increase inflammatory markers and increase oxidative stress, free radical stress, and we know that those factors can also be a risk factor for heart disease as well. We know that stress increases blood pressure. You can go on and on and on and see the link between stress and poor health outcomes. But let's take it a step beyond stress. It's not just stress. It's what's behind the stress, and that's what we're talking about, and that's what's important. And we really need to start looking at those deeper causes if we really want to get to the depth of the problem. Equity in health, relating to access to health care and health promoting environments and services is a really important issue that affects everybody around the world, and it's something which I think is constantly sort of being battled over. I think recently in Australia you saw that there was the Medicare co-payment debacle, where essentially wanting to introduce this payment might mean that people who have a lower socioeconomic status may be inclined to not want to go to the doctor. Do they have access to bulk billing doctors? What will be the ramifications for people that can't afford to see the doctors, and where does it head in the future? Does this co-payment therefore then lead to more and more increased costs up front for people? So these kind of debates and discussions are always going on in different communities. In America, obviously, they have Obamacare and various challenges with trying to create equity in healthcare in the US. And also, not just in basic services, we need to make sure there's equity in the quality of the care that's offered, so that it's not like one person is sitting in a bed in a broom closet in a hospital because there's no beds available. We really need to make sure that there's a good level of service available to people as well, and that's obviously important for good health outcomes as well. So as well as the social and economic aspects of health, we have obviously environmental factors as well. And we certainly know with things like coal-fired power stations that they release things like mercury. And mercury then accumulates in the oceans and the fish, and then we eat the mercury. And then there's potential health consequences for us. There's quite a bit of research looking at density of fast food restaurants within certain areas, and that people living in those areas are more likely to have excessive weight problems. And it's kind of like, is this the individual choice or is this the environment? We know that there's increased rates of asthma in certain places where there's a lot of air pollution. And so it's clearly a multifactorial issue. The social determinants of health is a holistic approach that really does look at all of those different deep causative factors of people's health. Now, how we go about addressing that, though, can be a challenge. I mean, I think as a health practitioner from a clinical perspective, it can seem quite overwhelming to think about, well, what can I do? How can I can't change people's housing conditions. I can't create a new park for the kids to play in. What really can you do? We do know that in order to try and achieve these public health and health promotion type initiatives, it requires a multi-collaborative approach. So getting a whole lot of stakeholders involved, from the grassroots right up to government level, and that when all these different groups work together, then some of these big structural changes can take place. So, have a think about it yourself. I mean, what role do you feel that a complementary medicine practitioner, maybe such as yourself in the future, what way could you play, what role could you play in addressing some of the social determinants of health? So just pause it for a second, then come back, and I'll keep chatting away about it. So, all right, so let's think about some of the factors which come to mind for me. So, as a clinician, one of the things you can start looking at is actually moving more upstream. So upstream means more prevention rather than dealing with the problems, which is more downstream. So a hospital is more downstream service. A naturopath sitting in a clinic and prescribing medicines for diseases is also downstream. How can that downstream model start to move more midstream or upstream, so more preventative? So it might be things like, could you start running groups where you get exercise programs going, you get very involved and committed in your community, and run weekly walks through the forest, or walks through shopping centres, or tours through supermarkets, helping people to understand about food choices, looking at some of the behaviours around food choice, some of the cultures around food choice, and looking at what role you could play in helping to be a part of that change. Maybe it's being involved in the local schools, and as a professional member maybe of a program to develop a healthier school, and you could advocate and be a part of that process. And therefore, when the kids are coming to see you in your community, if they're coming from a school that's promoting healthy foods and getting rid of all the artificial colours and preservatives and things as well, then what you do with that child is going to be a lot easier, because it's very difficult to get a child to not eat artificial colours if they're handing them out as treats and rewards at school, having special days where they give out artificial coloured icy poles and all that sort of stuff. So, so you can get involved. They're just a few thoughts of mine. Keep thinking about it, because it's an area I think that's really important for complementary practitioners to start thinking about. And indeed, the World Health Organization has, in the Ottawa Charter for Health Promotion, it basically recommends that that's what clinical downstream services do, and that is to start to look more upstream in what you can do. All right, so I'll leave it there for this part, and I'll come back in part 3 with this slide, the sociology, and where did it come from.